Okay, it seems the final count is final. So good evening, everyone, and thank you for your patience. We have been facing some technical difficulties. Finally, they are solved. Thank you for joining us and accepting our invitation today. My name is Muad Sousa. I am responsible for marketing at Stellar Greer Company in the Middle East region. It's my pleasure to welcome you all on behalf of Stellar Greer to this educational activity. Now, for those unfamiliar with Sturgeon Greer, it's a biopharmaceutical, a global company specializing in allergy diagnosis and management treatments, particularly in allergen immunotherapy or AIT. Now, with over a century of experience in allergy, Stellargen takes pride in offering an end-to-end approach from cultivating allergen extracts in-house to delivering the final AIT product to the patient. Today's this session is part of a series of online webinars running over the next 6 months with a primary focus on respiratory allergy and AIT. This program is organized in collaboration between Stellar Greer and between the Gulf Academy of Allergy and Clinical Immunology Society, GACI. And here I would like to take this chance to extend my sincere gratitude to Dr. Muhammad Abu Zaqouq, the head of the GACI Society, for his enthusiasm and for his invaluable support for this program. By the way, Dr. Muhammad will be our chairperson for this session. He's a distinguished consultant in the Respiratory Institute at Cleveland in Abu Dhabi, and he holds a PhD in immunology from Trinity University in Dublin. He also has an extensive academic experience in having served as a lecturer in clinical allergy and immunology at Trinity College in Dublin. Dr. Muhammad specializes in allergic conditions such as atopic dermatitis, food allergies, to rhinitis, asthma, and chronic sinusitis. So please join me in welcoming Dr. Muhammad. The floor is yours, Doctor. Thank you for joining us.
Many thanks, Muad. Thank you for the kind introduction. And it gives me really a great pleasure to welcome you all to the first series of Gulf Academy webinars. And this is really a joint venture. And I'm going to share my slides, if you can allow me. I hope you can see them. Can you see my slides?
We can see the slides. Go ahead, please.
Excellent. So again, like you said, Muad, this is really a joint venture between the Gulf Academy of Allergy and Clinical Immunology and Stellar Greer, which is a biopharmaceutical company which has lots of experience in producing allergy immunotherapy products as well as allergen diagnostics. Now, the aim of this program is to address different aspects of respiratory allergy and allergen immunotherapy. This is the focus, really, of these series of lectures. Allergen immunotherapy, as you may all know, is an important therapeutic area in allergy that is really not well understood and surrounded by lots of myths, particularly for non-allergists. Like Muad said, this is going to be a 6-month webinar series. Hopefully, the plan is to run one session a month. Now, each session features a different national, regional, and international expert in the field of allergy and clinical immunology, and it lasts approximately 2 hours. Technical glitches, like what happened tonight, permits. Now, your participation is really essential, and we need your feedback, questions, and comments, because this is a more of a two-way, education. So we deliver lectures, but we need your comments and your input as well. So please type your questions in the chat at the Q&A session after the talks. Now, just before moving on, I'm going to briefly introduce the Gulf Academy of Allergy and Clinical Immunology. This is a venture that was established in 2022 in the UAE, and basically the aim was to promote the Gulf region as a provider of state-of-the-art allergy and immunology patient care education, research, and training. Furthermore, the other ultimate aim is to foster collaboration among health professionals and promote the best practice to improve patient care and across the region, because this region is a unique. The population is mostly homogeneous, and usually the allergic disorders is really has similar patterns, if you like. Now, the Gulf Academy of Allergy and Clinical Immunology is partnered with lots of international, regional, and society, and we're really thriving. Although the age of the academy is only 2 years, but we've done lots of work in the improving the allergy immunology education in the region. Now, our partner for this series of webinars is Stalagen Greer, and this is a well-known global pharmaceutical company specialized in allergy diagnosis and treatment, particularly allergen immunotherapy. The main focus of Stalagen is on producing natural extracts that mimic real-life allergen exposure, ensuring precision and effectiveness in treating these patients with specific allergies. Now, we put together really a very interesting and rich program, which covers all areas or all aspects of allergen immunotherapy, and it's important. I'm going to talk about the mechanism that we think about that is really causing tolerance, if you like, to allergens, and the lot of unmet needs in this area, as I said, and hopefully at the end of this series, your knowledge in allergy immunotherapy has improved greatly. And as you can see there, the sessions are led and delivered by quite a number of regional, national, and international experts. Now, the first session tonight is going to be on allergic diseases, diagnosis, management, and identifying the right patients for allergen immunotherapy to ensure long-term adherence. And it's going to be delivered by my dear friend and colleague, Professor Carla Irani and Professor Andrei Kameev. Now, first, according to the program, Dr. Irani is going to talk about allergic diseases, diagnosis, and management, and then followed by Professor Andrei, who's going to talk about allergic disease, identifying the right patient for allergen immunotherapy to ensure long-term adherence. So without further ado, I think I'll give the floor to Professor Irani to deliver her talk. Professor Irani is a distinguished allergist and clinical immunologist. She is the head of internal medicine and clinical immunology division at the Hôtel de France University and Hospital in Beirut. She held several academic and clinical positions internationally, and her research interest really is focused on asthma, rhinitis, food allergy, particularly in the Middle East. And Professor Andrei Kameev is a renowned consultant in pediatric allergy and immunology with over 20 years experience. He's professor at Pavlov First St. Petersburg State Medical University. His work focuses on improving patient outcomes through innovative treatment and evidence-based practices. He's an expert in patient selection and improving adherence to allergen immunotherapy. So this is a brief introduction to our distinguished speakers, and I think we'll start our main talk. The first talk is by Professor Irani. So Professor Irani, the floor is yours.
Good evening, everyone. Thank you, Professor Abu Zakuk, for this kind introduction. I would like to thank Stalagen and the Gulf Academy for this very interesting partnership. And I'm looking forward to a fruitful meeting. So my part will be mainly talking about allergic diseases. Obviously, we'll talk mainly about respiratory allergy diseases, diagnosis, management, and to identify the right patient for AIT that will be taken care of later on by Professor Kameev. So when we talk basically about diagnosis, I think it is very important to introduce this part, talking about the prevalence, the symptoms, the management, Also understand the mechanism of action, the immunology part of allergic diseases, and then talk about the management. So just a reminder about the definition that allergy basically is over-responsive or hypersensitivity.
Sorry, Dr. Carla. However, we cannot see your screen. Are you sharing the presentation?
Muad should be sharing it. I can see the screen.
We can't see Prof. Carla's slides.
I'm sharing the presentation. Should we stop and reshare it again?
Yes, please.
Actually, currently I can see the Professor Mohammed Abu Zakuk screen. So the first should be.
I can see the screen. No?
I'll stop sharing. Sorry, stop
Yeah,
sharing.
yeah.
Oh, yeah.
It helps.
Better.
Perfect. Now perfect.
All right. Thank you.
Okay, thank you. We will start about the prevalence. And as I mentioned, by definition, allergy is a hypersensitivity of the immune system. It has a lot of immunological pathophysiology that we will talk about. So this is not a poor immune system. It's the opposite. It's the hypersensitivity to an allergen that people encounter. And it's very important that sometimes people say it's just allergy, but when we see how much allergy can affect quality of life, this will actually make us more eager to really know about allergy definition, prevalence, etc. And this is one of the most common disease, chronic disease. Definitely, when we teach allergy or a course about allergy, we think right away about IgE mediated, which are the most common, affecting more than 30% of the population worldwide. So the focus when we talk about immunotherapy is about the IgE mediated disease, knowing that when we say allergy in general, we can have other pathophysiology when we talk immunology. So basically, the prevalence is increasing all over the world. Around 30% of the global prevalence, so for allergy, and it changes between different continents. But I will share with you one slide about the prevalence in our part of the world, since this group talks about the Arab world. The impact on patients' quality of life is actually very important, and this is also important when we evaluate the diagnosis but also the management. It will cause, in addition to the physical illness, the stress, the decreased productivity, this affect usually young population, so it can affect school attendance or work attendance, so this is important. In addition, of course, to the cost part, this is a costly disease. Next. So just one slide about the prevalence of respiratory diseases in the Middle East, because this is very important. And you can see in the middle, for example, the Lebanon prevalence, but you can see also KSA and other Arab countries. And basically, the numbers as published in this paper are very similar to other papers published in the Western world. So basically, the prevalence in our part of the world is around 30%, which is very similar to Western world or to the US or Europe. This is another study also published about prevalence of asthma and allergic disease. And again, the prevalence can go as low as 5% to as high as 15%. Next. Okay, Now, why do people develop allergy? There must be risk factors like other chronic diseases. And what is very special about allergic disease is that the risk factors can be divided into three parts. The host-specific factors, so basically genetic background, if a parent has allergies, the immune response, how the age of the patient, sometimes it's hormonal between girls and boys, etc. But also there are other factors that are important, such as biogenic factors. So what is the patient exposed to? Whether it's microbes shifting the immune system from Th2 to Th1, or the opposite, less of microbe exposure, whether it's mites, molds, pollens, and we will see that in the other slides. And finally, the anthropogenic factors, which are the environment. And we know that all the publications in allergy talk about what we call the gene by environment interaction that is very important. And that's why a person who can have the risk factors but doesn't develop allergies unless all these environmental factors are there, such as pollutants, lifestyle, nutrition, etc. Without, of course, forgetting now it is the very hot topic that is all over the world, the climate change. So global warming, affecting, for example, pollination, where the pollen season, especially in our part of the world that is relatively warm, the pollen season can be not seasonal but perennial. And that is very important to take into account, especially when we talk about our part of the world. So why an allergen becomes an allergen? Because allergens are proteins, and we know that, and they need to be presented to the immune system by, for example, interacting with the epithelial barrier of the respiratory systems, whether it is the nose or the lungs. And also, they have to have a capacity to bind the specific IgE antibody that is secreted by the immune system, in particular the B cells. And this actually makes a protein to become an allergen. And we know that there have been many allergens identified, more than 900. And when we talk about, for the sake of this presentation, we are very interested mainly about the aeroallergens, whether it's outdoors, such as pollens, molds, or indoors, pollens, pets, or dust mites. But we shouldn't forget also that there are non-inhaled allergens, such as food, insect stings, etc., that are also important allergens. An allergic reaction, and here we are talking mainly about type 1 hypersensitivity, IgE mediated, but also other types, where we always need this rule. The patient has to be sensitized, so he needs to be exposed to the allergen first, and then the immune system will do the effector phase or the phase that we see clinically. So the sensitization is whenever the immune system encounters the allergen, and at that phase, the patient is asymptomatic. So having specific IgE alone does not mean the patient is clinically having the allergy. And that's why we always say we need to correlate clinically. So these two phases are very important. We cannot have a clinical phase without a sensitization. So we cannot have an allergy, IgE mediated, without having an exposure, first exposure to the allergy. Then we have the disease clinically, how to make the diagnosis. And I think as allergists, we have to work to have a work of a detective. This is very important. Clinical history is essential in evaluation of an allergic patient. And the clinical history, of course, is a history taken from the patient. But also what's very interesting nowadays is that even with the clinical history, we can have some objective measures, such as the ACT, the asthma control test, or the allergic rhinitis control test, because history alone needs to be into a structure, so with objective markers. So first clinical history, then we can have medical evaluation, of course, physical exam, that is very essential if the patient has allergy shiners, blocked nose, mouth breathing, wheezing, etc. And then we go into diagnostic in vivo or in vitro. And as allergists, of course, we will talk about our gold standard in vivo, which is the skin test, and then the in vitro, which is the detection of IgE. So it's really a process that needs to be followed in order to have the best diagnosis. When we talk about in vivo test, mainly we, as our gold standard as allergist is the skin test. And what we use mainly is the skin prick test, which is epidermal. It has a lot of advantages. It's convenient, it's low cost, and we have a very quick answer in the office of the allergist. And it's mainly recommended for respiratory and food allergens. Of course, sometimes it's not available or not possible. We will talk in different cases, in some cases, and then we need to do the in vitro. The intradermals is even also used sometimes by allergists. We can discuss this in the discussion about my opinion about intradermal. And then we can do the patch test that is for contact dermatitis. So for the sake of this presentation, I think the most important for us is skin prick test. And it is important to have a good technician and a good training to do a proper skin test, because finally skin test has to be well done, well performed, but also written or read properly. And in order to do a proper skin test, we need to know what we are testing for. It's important to know what we have in each country as far as allergens in order to know what to test for in the skin test. And this study we have published long time ago showing the different pollen that we have in Lebanon, for example, grass, olive trees, Parietaria, and Cupressaceae. And this is another paper also that we have published showing that when I choose to do a proper prick skin test, I need to choose the right allergens and not use the European or the US panel and make the diagnosis, because we know that allergens change between different countries, whether, of course, house dust mites is universal, but the pollen should be specialized. For example, in Lebanon, again, this is a list about the most common allergens that we have. And we can always discuss it in the Q&A. Then we can also perform a specific IgE. So specific IgE can be very helpful, especially if we are unable to do a proper skin test. But we need to be aware that specific IgE has different techniques depending on the labs. And that's why it is important to, whenever we order a specific IgE, to have to know the technique about the lab that they are using in order to have a good test. We have a lot sometimes of false positive or false negative. So again, this is important to have in mind whenever we interpret a specific IgE test. So basically, when you have an allergic patient, it is important to propose a management flowchart. So we made a clinical history, we made the allergen, what type the patient is allergic to, and now we have to offer him a proper management. Of course, as allergists, we always talk about avoidance measures that sometimes are possible, other times are not, and the proof we will show that is not always evidence-based. But it's always possible. For example, if you have a pet, although it's even with if you have a cat or dog and tell the patient to get rid of them, this is almost impossible. But we can always discuss avoidance measure, and we can try anti-allergy drugs, and we will talk a little bit about them, and then consider allergy immunotherapy. And I think that this chart is very basic. I think each patient is unique in a way. As specialists, sometimes we see very complex patients, and we can right away propose allergen immunotherapy if the patient has been suffering for many years. Just this slide is very interesting, showing that avoidance, that we still educate our patients about avoidance, especially for mites. Many studies showed that like in the dark blue that you see here on the slide, the high percentage of these avoidance measures do not work. Again, we still have to educate our patients, but I don't think this is very efficient, especially if you have a humid climate like we have in our part of the world. Of course, pollen avoidance is even more difficult. We tend to tell the patient to avoid pollen, but it's also very difficult to do. So avoidance is important, but not always easy. Pharmacotherapy, you know all about the classes of medication that we use, whether it is antihistamine. Of course, we always have to look for the second generation antihistamine that are used. We have the corticosteroids, and mainly corticosteroids topical, rarely oral for allergic rhinitis, sometimes for exacerbation of asthma. Decongestant, we have to warn our patients about the danger of long-term use of decongestants. We have the leukotriene receptor antagonist and the bronchodilators that should be always used with inhaled steroids in the case of asthma. Of course, they still list in the ARIA guidelines, etc., the anticholinergics, chromones that are very old, and I don't think anyone uses them. But with the AIT, we know now that there is also all these recent treatment that are very important, which are the biological agents such as omalizumab, dupilumab, or benralizumab. That are also very important in the management of respiratory allergic diseases. So, of course, we are at a nice time in the allergy field because we have many new treatment, pharmacological measures that help our patients. But despite all this panel or range of treatment that we have, we know that we still have a lot of limits, and many of our patients are still uncontrolled. And many studies showed that up to 40% of patients with allergic rhinitis remain uncontrolled, and they still have symptoms even when they start, for example, intranasal steroids, because we know that it takes time to kick in, and also the proper technique, etc. And some studies showed also that 25% of patients with allergic rhinitis are still trying new medications because they don't have a control of the disease. So this is very important also to keep in mind when we are seeing our patients. So pharmacotherapy, of course, is important, but sometimes it's not satisfying to the patient or has some limits. And that's why allergen immunotherapy actually brings this gap or this opportunity to control the disease. And we shouldn't forget that this is the only modifying treatment that we have for allergic diseases. So when we say modifying treatment, it's not symptomatic, it's a long-term treatment. And the goal of allergen immunotherapy is to induce tolerance and to keep this tolerance even after stopping immunotherapy. And this is very unique because sometimes patients are controlled with the medication, but whenever they stop, they have the recurrence of the disease. And what's very important is this personalized touch. So this is a personalized medicine approach that is used in many fields of medicine nowadays. And this is very interesting in the field of allergy. Of course, it can be applied in allergic rhinitis, allergic asthma, venom allergies, and nowadays even in food allergies. The list is not exhaustive. We still have also the role sometimes in atopic dermatitis. So if we go back to the most common allergens, again, when we talk about rhinitis and asthma, we have mainly the focus on aeroallergens. We shouldn't forget also the association sometimes with allergic conjunctivitis. That is a common disease that is associated to other respiratory disease. And we have also the other allergies that are present. I'll talk very briefly about each disease: allergic rhinitis, asthma, and allergic conjunctivitis. When we talk about allergic rhinitis, there is IgE involved. So the type of nasal inflammation is IgE mediated. And that's why when we talk about allergic rhinitis, it will be very important to try to identify the allergen that is causing the disease, whether it's pollen, molds, or indoor allergens, without forgetting that other factors such as pollution, smoking, etc., global warming can exacerbate or make this disease even more clear. So when we talk about allergic rhinitis, we need to think, what type of allergic rhinitis am I facing? Is it intermittent? Is it persistent? Is it mild, moderate, or severe? And basically how you do it in the clinic, you see if the patient has the allergic rhinitis is having a high impact on the quality of life, then it's moderate to severe right away. How much is affecting sleep? How much is affecting daily activities, school, work, etc.? And the symptoms that most studies actually show the efficacy of any intervention, whether it's medication or AIT, about the symptom score: nasal itching, sneezing, rhinorrhea, nasal congestion, with or without ocular symptoms. And that's why when we have the diagnosis, we need, again, like any allergic disease, to talk about the clinical history. We do a physical exam looking at the nose of the patient, see if there is any edema, if there are polyps, if there is discharge. Then go to the diagnostic with skin prick test or specific IgE, and then identify which type of allergen is responsible for the disease in this particular patient. And when we talk about allergic rhinitis specific IgE, of course, sometimes it's hard to find the allergen, and we can go even to more complex diagnostic tools such as the CRD or the molecular allergology, etc., that can help me do a better management. So the management, of course, if it's possible to do avoidance, we do avoidance. Then we give symptomatic treatments, and then we can go to really the order of choice doesn't have to be always AIT at the end, because if a patient has been suffering for a long time, or if the clinical correlation between the diagnostic test and the clinical history is very clear. For example, someone who has a cat, has allergy to the cat, then it's very clear he needs AIT. An adult patient who has been suffering, he will not have a spontaneous remission, etc. So AIT has a role here. And AIT has been recommended in many international guidelines. For example, in the AIT here, that AIT guidelines on allergen immunotherapy, allergic rhinoconjunctivitis, so in rhinitis and associated conjunctivitis, that it can be considered even if in less severe or mild to moderate AR. It doesn't have to be severe allergic rhinitis in order to think about the role of AIT in allergic management. So I think with the new guidelines, whether it is the AIACI or the WOW, we know that we do not keep AIT only for patients who are not well with pharmacotherapy, but we should move even quickly to, even in the initial stages of allergic disease, the role of AIT is very important in order to minimize the pharmacotherapy, but also prevent, for example, the progression from allergic rhinitis to asthma, and that's in the new guidelines. So the allergic asthma is also another IgE-mediated disease. Of course, asthma is a more complex disease. So the inflammation of asthma can be IgE-mediated, but also has other factors that play a role. But anyway, in a patient who has allergic rhinitis and associated asthma, we know that allergic asthma is here due to IgE-mediated indoor allergens, pollen, fungi, etc., and the other associated factors such as obesity, viruses, food allergy, smoking, and family history. So allergic asthma is more complex than allergic rhinitis, but when we have evidence and clinical correlation between the symptoms and the exposure to these factors, to the pollen, then or dust mites, then it is very clear. Same as allergic rhinitis, we have to take a good clinical history to do a physical exam. Here we can do lung function test, we can do FeNO test, and even bronchial provocation tests sometimes, in order to have this confirmation of the correlation between these allergens and the presence of the allergic asthma. But of course, bronchial provocation can be sometimes risky, and also is preserved only in specialized center. Management, a little bit the same: eviction, first line symptomatic treatment, but also to control the inflammation, ICS LABA, and then allergy immunotherapy. And what is very important is that nowadays allergen immunotherapy, finally, I would say, is in the GINA guidelines, because we fought a lot about this to really convince people that AIT is efficient in allergic asthma. And as you see in the box on the right side, that AIT might be considered as add-on therapy for adults and children who have asthma, and clinically significant sensitization to aeroallergens. So finally, AIT is in the GINA guidelines, and not only for dust mite, but also for pollen, and same for AIACI recommending house dust mite, for example, slit tablet for allergic asthma in their guidelines. I spoke a little bit shortly about biologics. We are in the biologics era, and we know that in order to prescribe AIT to an asthmatic patient, you need to have a control of the disease. So even in severe diseases, we need to reach control sometimes with biologics, and then add AIT. And the slides down show you the group 1, which is the actually light line that you see on the top, where we use standard therapy dupilumab and AIT. It was started 3 months after initiating the biologic, and this is very important to control the disease and initiate the AIT. The group 2 is standard therapy without dupilumab. With AIT, also you have an improvement. This is the dotted line. And then the standard therapy without AIT, without dupilumab, of course, the asthma control questionnaire is very high and the FEV1 is very low. So this is also a opportunity for asthmatic to benefit from AIT after controlling them with the biologics and AIT. So again, the AIT guidelines talk about the role of AIT, in particular to house dust mite, to achieve, to facilitate achieving asthma control, and also as an opportunity to have a better control and hopefully even a complete control of the disease. Definitely with the, we need to control our asthmatic with pharmacotherapy before initiating AIT. Another respiratory disease is allergic conjunctivitis. Here it's even more annoying and more affecting quality of life. And we really need to ask about our patient about this disease, because this is a very debilitating disease and can have a lot of scars in the future. In ophthalmology world, we have a lot of allergic disease, but the immunotherapy basically is reserved to seasonal or perennial allergic conjunctivitis. The more complex disease, such as the vernal or atopic keratoconjunctivitis, are not the subject of our study today. But just to tell you that basically 80% of cases with allergic rhinoconjunctivitis are seasonal, according to some studies. So there is actually a place for AIT in IgE-mediated allergic conjunctivitis once we identify the allergen. Sorry. So basically, the management of allergic conjunctivitis is also complex. We know that the eye is an immunologically, we call it isolated organ. So that's why we need all the topical treatment in the eyes. But we have to be very careful, especially with topical steroids, because of all the side effects we have with long-term topical steroids in the eyes. And I think the AIT can also be a good opportunity. So the final 2 slides are about the atopic march, where we talked a lot about atopic march. I like the atopic march, but I think also it's very important to know that it's not all the time in that order: atopic dermatitis, food allergy, allergic rhinitis, or allergic asthma, because nowadays we see many patients moving from one type to another, sometimes adults having allergic asthma and later on developing atopic dermatitis. But I think AIT is here whether to prevent or also to treat these diseases in the atopic march. So in conclusion, I hope I showed you that allergy is an over-response of the immune system. It can affect 30% of the population worldwide. It's very important to have a proper diagnosis and management strategy. It has to be, of course, clinical history testing, but it also has to be like an analysis or like a puzzle, where we do the clinical history, the diagnosis, and then we offer the proper management. We know that we have a lot of pharmacotherapy, but we still have our patients who are not satisfied. So we are here to, of course, use or have the opportunity to use allergy immunotherapy in the right patient at the right moment. With that, these are my sources, and I would like to thank you for your attention.
Many thanks, Professor Irani. Thank you very much indeed. This is really very informative. I think we'll probably move to Professor Kemev and have the questions at the end of his talk. So please go ahead, Prof. Andrea, and just give your talk. The floor is yours. Thank you.
Thank you, Professor Mohammed, and thanks a lot to Professor Carly Irani, who had delivered us a brilliant lecture of the whole topic of allergic diseases. And my topic today is how to identify the right patient to start this really disease-modifying method of treatment, allergen immunotherapy. And I'll start with some slides which will go in line with the topics covered in the previous presentation. First of all, I would like to notice that to become a specialist in allergy is a very perfect idea for young carriers, young doctors, because nowadays this is the era of the non-infectious diseases, and allergic diseases are among them. These diseases are chronic. The prevalence of allergic conditions always arising in different parts of the world, and allergic diseases could be controlled by pharmacological substances, but sometimes we can see effect of declining of the efficacy of pharmacological substances. And it's very important thing which was covered by Professor Irani, that the most allergic patients have multimorbidity. You always should ask about asthma in allergic rhinitis patient, ask about allergic conjunctivitis complaints in a patient who come to your office with just sneezing. This means that each visit will finish with a lot of drugs prescribed by a doctor, by an allergist. And immunotherapy is a tool to decrease the number of the pharmacological load per the patient with the concrete disease. Allergic patients tend to expand the culprit allergen spectrum. It's not only the molecular spreading, as we can discuss after the CRD component resolved diagnostic, but also with, especially in the uncontrolled settings of the allergic disease, a patient become more and more allergic to different sources of allergen and to different parts of the allergic spectrum, inhalant allergens, food allergens, or even contact allergens. And yeah, sometimes we can face the escape phenomenon, which is very unpleasant surprise for our patient. Then old friends, drugs which were prescribed in the previous century stop to show the efficacy, and we need to find more and more molecules of antihistamines, of anti-leukotrienes, even another new molecules of topical steroids, because in some patients we faced the phenomenon of the depleted efficiency. Immunotherapy, allergen immunotherapy is not only well established, but very modern tool to control and to modify the natural course of the allergic disease itself, and to prevent the changing of the phenotype of the patient's complaints. And nowadays, we are not struggling and we are not choosing between pharmacological substances and the immunotherapy. There should not be any neglecting of the both side of these controlling tools. We can start with the getting the pharmacological remissions of bronchial asthma or allergic rhinitis, and then combine the pharmacological treatment with allergen immunotherapy. It's the best way, in my opinion, and we can discuss it later in question and answer session. All the current available pharmacological substances are working only in the moment the patient takes them. And this is a very pity story, because a lot of patients come back to a doctor's office and say, you have prescribed me a very bad medicine because it finished its action after a month, then I stop it. Instead of this, allergen immunotherapy is a long-term type of disease-modifying treatment, but it still works after the discontinuation of the intake of the allergic vaccine. And it's very important. And a lot of things, a lot of features, which in some papers you can find as a bad features of the immunotherapy, are absolutely clear the features of the pharmacotherapy also. In some drugs, in some medicines, we can see a possible individual response, especially for anti-leukotrienes. The need of daily intake of medicines make a financial burden for a family or for a patient himself. In some regions, there is low availability of innovational drugs like monoclonal antibodies, and the quality of life hardly depleted by the need of daily intake, of regular intake of the treatment. So in these terms, we have not a lot difference between allergen immunotherapy and pharmacological therapy, pharmacological treatment. But allergen immunotherapy always have a very important benefit that it still works after the discontinuation of the intake, after the finalization of the whole course of immunotherapy. I will not stop on the elimination strategies. It was covered by Professor Irani, but I can say that it's very important to start to control patient before starting the immunotherapy, and these will help you very to have a established period of immunotherapy, more quiet, more easier for a patient and for a doctor who prescribing the immunotherapy. It's very important that allergen immunotherapy works in a different way on the cytological level, on the molecular level, than our works of the immune system with a natural exhibition of the natural allergen contact in a case of pollen season, for example, or in a case of contact with a pet. During the allergen immunotherapy, different dendritic cells present the protein of the allergen, and a different type of polarization of naive CD4 plus cells starts, and different region of the immune reaction. It's not the submucosa region, it's in regional lymphatic nodes. So we have finally different type of mediators, different type of cytokines. And the most important of them is the IL-10, which is well known to be downregulating the inflammation and especially the production of new Th2 cells. And these also, and for the differentiation of dendritic cells also. So prescribing for a patient the course of allergen-specific immunotherapy, we not only diminish the reaction to the specialized allergen, for example, birch pollen or grass pollen or house dust mites, we also helps to make the reactions to the other allergens less clinically less active, because there will be a production of non-specific anti-allergic cytokines during the allergen immunotherapy, and this will help not only to prevent the spreading of the sensitization spectrum, but also this will help to make the reactions to the previously established allergens easier and with less active clinical symptoms. But to have this curative effect of allergen immunotherapy, we have to continue the immunotherapy course on the high dose, highest doses which is tolerant by a patient. The dose intake should be regular. The duration of the course should not be less than 3 years, and there should not be a lot of adverse reactions, because sometimes with a very fast introducing of the treatment allergen, we have some patients who are reacting on the treatment allergen. Any course of allergen immunotherapy should be minimum 3 years, but normally, and it's listed in the prescription leaflet in the instruction of use of the medication for the immunotherapy, it should not be longer than 5 years, because in clinical settings, the best you can achieve from the immunotherapy is achieved on the 4th or 5th year of treatment. And the clinical effect is normally achieved on the 2nd year of the allergen immunotherapy, and it's very important to continue the treatment course, not less for 3 years. That could establish immune tolerance, which will last more than the course of allergen immunotherapy. And the duration of the immunotherapy and adherence of a patient to the prescribed vaccine is the cornerstone of the whole efficacy and especially of the duration of the effectiveness of the course after the stop of intake of the medicine. So the ideal candidate patient to start the immunotherapy is a patient with well-diagnosed allergic disease, allergic rhinitis, bronchial asthma, or atopic dermatitis. And in my opinion, the best patient is the multimorbid patient. Pharmacologically controlled, patient with pharmacologically controlled disease. Well-established clinically relevant sensitization to inhaled allergen. It was clearly established in the Professor Irani presentation that you should not only check the list of the so-called positive allergens in vitro testing or readings from the skin prick test. You should combine the results of the evaluation with the clinical history. It's very important. No contraindications, and patients willing to start the 3 or 5 years collaboration with the doctor. And here comes the adherence is as main reason of inefficiency or lower efficiency of the immunotherapy in a real world clinical practice. Unfortunately, adherence is a main trouble with any chronic disease medications, and also it's well known to be a reason of inefficiency, like in a half part of the patients who have started the immunotherapy course. 50% of patients discontinued immunotherapy in the first year. And unfortunately, only 10% of patients completed the full 3-year course. It's very important to discuss this problem with patients and to improve the adherence level. Adherence, it's not a genetic feature of a person. It's a modified factor, but very important factor. And we will come to the possible modifying approaches to improve the adherence to immunotherapy. Prescribing and refilling. As a practitioner, you know that among your prescriptions, only half, or in some cases, only 1/3 part will be refilled by a person, even in cases then the medication is covered by insurance plan or something like that. And especially in the cases then a patient need to pay himself for a medication. In my country, for example, allergen immunotherapy is not covered by any state insurance plan, and all the patients have to buy themselves the medication for immunotherapy. Nevertheless, most of the patients who completed the immunotherapy course and get the results, they become like ambassadors. They start patients' topics, internet discussions, and they bring to others the feelings about this type of treatment and the freedom of depletion of the medication load. The success of allergen immunotherapy may be depleted by allergen extract properties, inappropriate diagnostic approach, for example, and the cooperation fail. I think the cooperation fail is a main reason of the inefficiency of immunotherapy, but there are also some other factors. For example, on the diagnostic stage of the evaluation of the patient, we can lately diagnose the severity or the allergic rhinoconjunctivitis itself or allergic asthma. Misperception of severity could lead to the inefficiency of allergen immunotherapy, unknown contraindications, unrevealed concurrent sensitization. It's very important to complete the clinical history and to improve your knowledge about the culprit allergens in asthma or allergic rhinitis in the patient. And comorbidities could be a factor which deplete or which make lower the efficacy of the allergen immunotherapy. Proposed answer is a strict algorithm for the patient selection and evaluation and management and re-evaluation of efficacy of the acid during the course. It's very important not to lose the patient during these 3 years of very effective treatment, but very time-consuming and the treatment which very susceptible to the educational level of the patient and the understanding of the steps of the treatment. From the patient, very important factor to understand the goals of the treatment. If you tell to a patient that after 3 years of the allergen immunotherapy, your symptoms of the rhinitis or rhinoconjunctivitis or even rhinitis and asthma will be under control without daily intake of the medications. It'll be a very important goal, and this goal will be achieved in a higher probability than if a patient will not understand why we are doing all these 3 years treatment. Patient's engagement and decision share making. It's very important during the course, and for this long-term treatment, there are a lot of protocol violations could occur. So to prevent this, we need to discuss on each visit the quantity of the medications of the allergen extracts taken by a patient and to arouse new goals of the treatment. Patient educations, pre-course leaflets, any type of educational materials also provided by our producer of the treatment allergens is very important in my work. and web-based resources for information. Some of them will be covered during this presentation. Treatment factors: stop of the allergen immunotherapy after light adverse events. It's inappropriate, but quite often in real-world settings, we need to explain the patients the nature of these adverse events and the terms of their stopping. And we know that in the establishing phase of the immunotherapy, there could be some adverse events, but in 4 to 6 weeks, a patient will get the early tolerance to the allergic vaccine, and we will have a absolutely normal intake of the treatment allergen. Low maintenance dose, very important thing. We always have to fight for a highest tolerant dose during the 3 years of allergic treatment. Wrong choice of immunotherapy preparation. The main thing is to choose the culprit allergen and to understand not only the sensitization, but clinical relevance of the different allergens, which could be positive during the tests. We have to reevaluate the test with a clinical history. It's very important. And the wrong choice of the delivery mode. Now we have a sublingual immunotherapy and subcutaneous, and I myself, working as a pediatrician, prefer to have a sublingual, definitely. Even faced the story of the misadherence or miscommunications. And it's just a part of my work. I need to explain and re-explain to a patient, to his parents, what is important during this treatment. Patient indications, regular checkups, and continuing counting of the used medication packages is very important on the establishing of the adherence to the allergen immunotherapy. Regular daily immunotherapy intake could be ruined by forgetfulness, and it's very humanly to forget something. You need to work as a psychologist to explain and to make it easier to follow for a patient your indications. Intolerability and active decision to stop the immunotherapy. We'll discuss this in the slides later. It's humanity to miss something in the periods of 4 to 5 years as a normal course of immunotherapy. And a doctor should highlight the duration of one blister during the tablet sublingual immunotherapy or one vial utilization if we use natural drop extracts. Patient-entered locks. It could be paper or web-based locks on the consumption of the treatment allergen is very important to improve the adherence. Always ask about the quantity of used medicine. Give a monthly assignment of allergen consumption. It's very easy, but then you tell to a patient, on this stage, you should consume 1 vial per 2 weeks per fortnight. It's easy to understand if something goes wrong. And finish your consultation with next visit plannings. Let me teach you Russian in 3 minutes. It's my own leaflet, which I give to each patient using the sublingual immunotherapy with natural extract of birch pollen. Birch pollen is very important tree allergen, like an olive pollen, for example, in a Middle East area for my region. So what we have here, it's just A4 paper leaflet, which could be printed on each visit, and this paper should be personalized. This block is the patient's name and therapy name and instructions for use. 1 times daily, number of the pressings, sublingual, don't swallow for 1 minute at least, and mark the consumed allergen in the table. Here is the establishing period for 10 indexes of reactivity per milliliters vial, and then 300 indexes of reactivity per milliliter vial, only for 9 days. And then there are regimens for the main course of immunotherapy. Then a patient use 2 or 3 doses of violet vial, 300 IR per milliliter vial, and the number of the days which should be taken for 1 vial. There are some contraindications for concurrent vaccination and comments on the acute respiratory infections and reason of dose skipping, for example, orthodontist and stomatologist visits, and the dates for the using of violet vials. Number 1, 2, 3, 4, 5, 6, 7, 8, or 9, 10. For a pre-co-seasonal protocol, there are no more than 10 vials for the course. And finally, next visit date. So only 1 A4 paper sheet may cover and condense 5 months of the very time-consuming treatment, and after the end of these 5 months, you can see all the work made by a patient's family, and you can put it into your chart, and this really helps. We have protocol comparing written visit schedule and the plans of the 4 years house dust mite sublingual immunotherapy, and the controlling group who have not these pre-printed visit schedules and leaflets on the consuming of the treatment allergen. And even on the first year of treatment, there is a difference between group who have printed notifications, and these difference become statistically significant on the 3rd and especially on the 4th year of the sublingual immunotherapy. So on a different regimens, a vial of natural extract of allergen aqueous solution should be used in 3.5 weeks on the 2 doses daily, on 3 doses daily, 2.5 weeks, on 4 doses less than 2 weeks, and on 5 doses daily means our highest proposed by an instruction dose of 300 indexes of reactivity. It's only 9 days per wheel. And if you use a tablet sublingual immunotherapy, normally 1 blister takes roughly 1 month. So 1 tablet per day, it's a normal regimen of the tableted sublingual immunotherapy. So a patient have to refill the prescription each month, or use 3 months blocks of the tablets. Lack of compliance could be caused by intolerability, but adverse events are manageable, and antihistamines are not contraindicated during the allergen immunotherapy. So we have to just explain patients that it's normal, and these adverse events, local adverse events, will end in 4 to 6 weeks after the start of the treatment. Special advice should be given to polysensitized patients, to patients who demonstrate very high results during the allergen testing, for the patients with longer duration of the disease before the start of the immunotherapy. In pediatric population, we should specially advise parents during the changing of the teeth, baby teeth to constant teeth, and patients are undergoing orthodontic treatment, and patients who experience food cross-reactivity. In other conditions, no special advice should be given. We just have to explain patient that adverse event could appear, but they should be resolved by antihistamines or modifying of the dose. The tools to work with adverse events are education, temporal reduction of the treatment allergen dose, antihistamines, spitting after sublingual exposure, after 2 minutes under the tongue, no swallowing. This could be discussed, but not many patients need this advice. Allergen intake after meal, and investigation of the brush-informed color, especially in babies who are changing their teeth. If the color becomes rose or even red, it's better to stop or interrupt for a moment intake of the treatment allergen. We have to endure only 4 weeks, in severest cases 3 months after the start of the immunotherapy, and the future is much more easier after the establishing phase. The prevalence of the adverse events easily decreasing. Regular intake of highest tolerable dose should always be recommended, but in sometimes we can decrease the dose to keep the patient in the protocol of the intake allergic vaccine. So we have briefly discussed that there is a fast desensitization phase, which takes no more than a month. Then the phase of the early tolerance, which normally takes 3 months from the start of the immunotherapy, and long-term tolerance establishment, which takes more than 2 years. That's why the shortest course of the immunotherapy should not be shorter than 3 years. Unfortunately, no current biomarker available for the clinical practice to predict the number of adverse events or severity of the adverse events, but the patient should be consulted and should be managed during the course. And the executive decision, the best model now is a shared decision making, And we know that adverse events are a very rare reason of stopping the immunotherapy. The main reason is loss of contact and perceived treatment inefficiency. Unfortunately, on the third and on the fourth year of the immunotherapy, not only the treatment inefficiency, but supposed by a patient efficiency of treatment also could be a reason of termination, early termination of allergen immunotherapy, and this also should be discussed with a practitioner. We know that after the structured education, the adherence to the sublingual immunotherapy improved, and this was published like 15 years ago. Long-term effects depends on the duration of the immunotherapy treatment, and expected adverse events and possible control tools should be discussed during the before the start of the immunotherapy. And each visit should be the explanation to a patient that there is a necessity of daily intake of the allergen. And you know that if a patient have a 4 visit per year, this group have a best result on the treatment adherence, and a patient group with 1 visit per year often stops their medication, immunotherapy, before they are getting the result, before they are getting clinical improvement. I want to provide you some clinical illustrations with
Professor Andrea, can you
results.
just make it quick because we're running out of time?
Yeah, just one clinical illustration, and we'll finish. An adolescent with recurrent acute respiratory infections, with clear atopic history, eczema on the first years of life, atopic heredity, and positive results of skin prick tests and in vitro tests, very clear. Natural extract of house dust mites, immunotherapy starts for 3 years, from August 2018 till April 2022. No significant breaks during the course, and build-up phase with slight temporal itching in the mouth, and no reactions from the third month of treatment. At the end of the treatment, no symptoms of allergic rhinitis, no sneezing episodes, and even concurrent allergen sensitization to the cat become clinically more easier, and no asthma exacerbation during this treatment. Effective immunotherapy gives us assured symptom control, no asthma development, rare episodes of acute rhinitis, and no regular intake of the pharmacological controlling medications for the allergic rhinitis and for the bronchial obstructions. So we have no development of bronchial asthma. Nasal congestions, almost none, even 2 years after the interruption of the immunotherapy, after the ending of immunotherapy course. And even for bronchial asthma, we can have good results with natural extracts of house dust mites. And in some patients, we can modify the dose in the situation of a lot of breaks due to acute respiratory infection. But our goal should be to achieve the most weeks in the year covered by immunotherapy. And in this second patient, we have on the 4th year of treatment only 2 breaks and 48 weeks during the year covered by immunotherapy on the highest available dose of 4 pushes of natural extract. Sublingual immunotherapy started in childhood is a very good idea in most patients because we can prevent the development of bronchial asthma or decrease the number of medication need to be to control this disease. And in most patients, we have a depletion of the number of antibiotics courses during the year due to the better control of allergic diseases. So the final comments is the using of web-based applications is very popular in other chronic diseases, and this tool could be also useful during the immunotherapy and the improvement of the intake of the allergen, adherence to the allergen immunotherapy could be aroused by web-based education and web-based resources of daily intake of the medication. Patients with bronchial asthma and allergic rhinitis need more information about their disease course and treatment long-term effectiveness. Allergen immunotherapy could be the only mode of treatment that decreases future risk of spread of the sensitization, of the growth of the severity of the disease, and transition from rhinitis to asthma along this decline of drug load. Allergen immunotherapy is dose-dependent treatment, and any doctor should inform patients about the necessity of almost daily consumption of treatment allergen and the duration of immunotherapy should not be shorter than 3 years to achieve the best results, clinical results of this treatment. Treatment adherence can be improved through the patient's education, regular visit and during the treatment, and scheduling the medication consumption until the next visit and per month, and active recognition of the adverse reaction and active management of these adverse reactions. I'm happy to finish my presentation, and if we have time, we can start the question and answer session.
I'd like to thank our 2 eminent speakers for their excellent talks. I think we did very well time-wise. We hope to finish in about 17 minutes according to plan. So I would like to thank also our participants. About more than 400 participants are staying with us till late. So I'd like to express my gratitude for their enthusiasm to learn and for their patience. So we have a number of questions coming from the audience. I'd like to we'd like the audience to interact with us and send questions, because this is really very, very important, because we have 2 eminent experts in the area. So I think you should keep your questions coming. Also, I just want to remind you that this is a CME accredited educational event. So you'll get a CME, 2 points of CME after finishing and after responding to the survey that will be sent shortly to you. Okay, so we'll do the questions. I have a number of questions from the participants, and the first question relates, to basically. I think this was answered with Dr. Carla Irani about the GINA guidelines and why allergen immunotherapy is omitted from GINA guidelines despite course-modifying capability. I think you've answered that question, and now GINA guidelines includes allergen immunotherapy and has been actually in the GINA guideline for a while. So that is one of the questions. The other question relates to IgE specific testing, and this really an important question. So we do allergen specific IgE tests, and we do skin testing. So in your experience, and this is a question to both of you really, because you do see a lot of patients with allergic disorders. So which one is better? Because sometimes we are faced with this question. Sometimes patients say, look, blood test is more specific, and patients actually come and request the blood test. Others come and say, look, doctor, I want this test that you put on your arm. So which one do you recommend? And what is the difference between the two tests, if you like? We'll start with Dr. Carla, since she brought up the diagnostic.
Yeah, thank you. So I think as allergist, I tend to do more skin testing if it's available, if the patient can stop the antihistamines, etc. But the new guidelines or conferences or lectures talk about also the benefits of specific IgE when it's done in a good technique. The only problem is that many commercial labs don't have good specific IgE like value. So if we trust the lab where it is done, the technique, I think both are feasible. Again, also the problem with skin test, if it's not done by someone who is well trained, also the interpretation can be wrong. So basically, it's both are good tools, should be done properly. The skin test by a good technician or a physician, and the specific IgE with a good technique.
Any thoughts, Professor Kameev? Any thoughts?
I can just add that in acute conditions, we cannot perform the skin tests. And normally, in most of my patients, I've got both of the results, skin prick tests and previously done blood tests also. Any of them should not interfere with the clinical history. And normally, both results should be positive. If it's okay, you can start the immunotherapy.
Well, I think the take-home message is that really don't do allergy testing unless there is a clinical history, because the issue and this is really the take-home message, and this is a very important take-home message, because although patients come and demand, and this is the practice we see here, for example, they come and demand allergy testing and allergy screens, and this is what causes their confusion. So they go to this person who's not trained in allergy and autoimmunology. They do these screens for them, and they give them the results to interpret through Google, and the patients come to us confused, etc., etc. So I think the take-home message really is don't do allergy testing whatsoever without a proper history, because proper history, everything starts with a proper history, and this what really drives and what directs the testing. Excellent. Now, another important question, which this is a very clever question actually, and not too many people would think about this, because the question is about, and this is for Dr. Irani specifically, do you recommend using stellar point or needle for skin prick test?
That's, yeah, very interesting. I think stellar points are the best, but again, the needles, it's the very old technique. And so I use stellar points. So,
Right. Okay.
but again, I mean, skin testing, it needs practice. So with the test and with the interpretation.
Okay. What about you, Professor Andreas? So what's your thoughts?
Unfortunately, in Russia, we have no stellar points. I've used them during the clinical trials, and I do love special devices to make a prick test. But I can say that a good technician could perform a perfect prick test with any type of sharp instrument.
Okay.
It could be performed even with the needles, I can say.
Okay. Now I'll tell you my verdict on this. It's not my verdict actually. There is a publication by AIT many years ago, and they've compared different needle products, and they came up with the metal needle is the best of them all. So, so the metal needle is the one I think maybe I don't think it's changed because I've used both, and I found the metal needles better than the plastic ones. So this is something to consider. And there is a publication in IACI. If anyone interested, we can you can PubMed it and check it there. But again, like you said, it depends on the operator. So if you have a good operator, a good person who is really familiar with skin prick testing and the interpretation, yes, you get a good result, and you can build your therapy plan based on that. So this is really important. Now, just going back to the prevalence, Dr. Arani, about, is there any, because, the MENA region, which extends from Morocco to maybe Iran, is different. So, for example, we have the North Africa and we have the Middle East. In terms of the prevalence of sensitivity, has there been any publication about what is most prevalent in what region? So, for example, if you look at Lebanon, the basin of the Mediterranean basin, which includes the different countries there, would have, for example, a different pollen allergen than the Middle East. So, for example, if you look at Lebanon, for example, we see people with olive tree sensitivity, similar people coming from Jordan, etc. While olive tree is not really a very common allergy in the Middle East. So have there been any publications or studies to look at different allergen synthesization across the MENA region?
No, I mean, each country did some studies. And what is very interesting, I think, is that it's true that different pollen exists in different part of the world or part of the Middle East, but it's important to know that we do have pollen in all this region, even though it used to be thought as desertic. I'm not talking about Lebanon because Lebanon is a Middle Eastern, we have a lot of pollen. But even there have been publications, for example, in Kuwait or other countries, and even now in the UAE, I think grass pollen is a major problem. So, and also there is some cross-reactivity. For example, the olive tree pollen belong to a family called Fagaceae that can also cross-reactive with ash, for example, in different parts of the world. So, it's single publications. No one looked like in a complete study, like collaborative study about each patient, but this is actually a good proposal for research and for epidemiological study to be done. So I think with your academy, I think it's a nice project to perform.
Absolutely. Now the thing is, one of the things that are missing is the pollen count. We don't have we're in the process of having a pollen counter for many.
We did pollen count, and we published some studies like back in 2012, I think, or 14. I think doing public count is important for identifying the allergens. For continuity, I don't know how much it's important, but for identifying the panel, that's what the study I've shown, to identify which panel to choose for skin prick testing and for AIT.
And that's very useful, actually. Your study is very, very good. Now, again, just going back to SLIT and SCIT. So the question is related, which one do you recommend for efficacy, SCIT or SLIT? Again, either of you, Dr. We'll start with Dr. Andrea first. SLIT or SCIT? What's the verdict, efficacy-wise?
Efficacy-wise, both of them are brilliant. The choosing is not based on the efficacy, but on the availability of the products, for example, and in sometimes on patient's preference. It's very important part of the adherence constructions. When you ask patient, which one would you prefer, having in mind that both of them are equally efficient.
Excellent, because if you, I mean, again, depends where you're coming from or where you're practicing. For example, you know, in the States up to recently, the commonest allergen immunotherapy route was SCIT. And then for various reasons, okay, not necessarily efficacy, but it's probably you know, it's a money generating you know, practice, if you like. But again, I agree with you, efficacy is similar and depends on the overall, and depends on the availability. I think we're lucky to have both available, and I think it depends on which one is available, which one is really going to work for that patient, because we have patients coming to us from, you know, 200-300 kilometers, and it doesn't make sense to give them or to offer them SCIT because they can't commute to get their injection. So again, I think we like you said in your talk, and Dr. Irani, where you said it's individualized, so it has to be tailor-made. The management plan has to be tailor-made to every patient, if you like. Now, again, pregnancy and immunotherapy. So what's your view on that? Dr. Irani?
Yeah, so for me, especially for SLIT, I do, if a woman gets pregnant within 3 or 4 months of starting SLIT, I do not stop, so we can continue. I don't start SLIT for someone who is pregnant. And that's also the advantage of SLIT, where, I mean, of course, SLIT and SCIT are efficient and each patient has its preference, but also it's very important to highlight the safety of SLIT compared to SCIT, even though, of course, nowadays the SCIT products are good and safe, but it has to be done by really specialized center where you have equipment. Even, I mean, one anaphylaxis in 100,000, it's still one anaphylaxis. So whereas for the SLIT, the safety is efficient. But for pregnancy, so if it's already started within 3 or 4 months, I continue.
Excellent. Now, the couple of questions here directed specifically to you. So how do you manage the gastric side effects of allergen immunotherapy? I think this is probably related to SLIT more than SCIT.
Yeah. So as Professor Kamayev said, that patients can spit it out, and I instruct them always to eat right after, and they can take a PPI the first month, and usually it should be fine. Now, there are very rare cases of patients who have already reflux or EOE in the past, then it has to be discussed ahead.
Great stuff. Yeah. Now, again, these coming questions are for you specifically. So, do you prefer continuous or periodic treatment of seasonal allergies? I believe this is related to SLIT as well, or SCIT.
Okay, so for pollen, and it depends on the pollen. For example, for olive tree pollen or grass pollen in Lebanon, we know the season. Then pre and co-seasonal is very efficient. It increases the compliance of the patient. For some pollen, like Parietaria, which is a weed that we have very prevalent in Lebanon, which is almost all year round, I choose all year round. So, but pre and co-seasonal is very effective for compliance.
What about you, Professor Andrea? Any comments on that?
Yeah, I do agree with Professor Irani. I understand that if it depends on climate, if the allergen has defined intervals during the year, it's better to have it pre and co-seasonal. If it's like ambrosia or something like that, or for the house dust mites, you have no other choice than all year round.
Yeah. Now, we did a study with a grass product that was published like many years ago, where we give the product pre-seasonal and continuous. So two groups where we gave them this product pre-seasonally and stopped when the season is over. And we compare this group with people who took the product all year round. And I did that. I used to work for the NHS, and we were trying to cut cost. And we found no difference. So people who were treated for 3-year periods continuously compared to those who had the treatment pre-seasonally. So there was no difference in terms of efficacy. Long term, we haven't really observed any, for at least 2-3 years in these two groups, there was no issues at all. So I think probably be more cost effective in seasonal allergies to do it pre-seasonally. So this is just a thought there. Now, I think for the sake of time, I'm going to finish with the polysynthesized individual. I think the polysynthesized individual is really the challenge for all of us. So how would you deal with the polysynthesized individuals, Professor Irani? Needing these individuals needing immunotherapy.
Right. So polysensitized are a big group of patients in real life, and with all the new studies, I think, and as Professor Kameev just showed, that when you give AIT to one that is the most clinically relevant or which the patient is exposed to, the rest may decrease. So basically, I choose with a clinical correlation. I follow my patients 2 seasons, the dust mites, which is here in Lebanon, for example, fall and winter. And then in the spring, I ask specific questions. If, for example, they are allergic to a special pollen here, and when they travel outside the Middle East, they don't have the symptoms, then I know that this is not the one. So basically clinical correlation. And rarely I can give 2 vials with 2 different allergens. I usually never mix, except maybe 2 pollen together, but I rarely don't mix. But the message here is that polysensitized patients have the right to and would benefit from AIT. Just the choice is by patient, personalized medicine.
Excellent. Professor Kameev.
Yeah, I have to agree. It's a perfect decision. Polysensitization is not a ban. It's not a contraindication to start the immunotherapy. And in some patients, we can combine 2 different allergic vaccines, like immunotherapy to grass pollens and tree pollen, or grass pollens and house dust mites. But never mix them, never perform more than 2 immunotherapies.
Excellent. You mean not to perform 2 immunotherapy? What does that mean? So you give 2. Are you talking about 2 vials or mixing allergens?
But you can mix 2 vials, 2 different vials.
2 different vials. Okay, so you can. Now we do mixing. We do mix, of course, pollen and we sometimes give actually, this is my practice is we sometimes I give up to 3 vials because the patients sometimes have a pet, but they have a perennial allergen, but the problem, and they have a cat, and when they go to the farm they have a problem with the horse. So and they have lots of their allergy is perennial, though they have house dust mite, they have tree grass and wheat pollen, and so it is really difficult, and it's not fair on the patients to expose them to 3-year treatment without covering most of the allergens, if you like. But it's I mean, again, so we need I think we need another hour to discuss immunotherapy, etc. We don't have the time, and I think adherence and compliance is a major issue across the board. And I'm not sure in Russia, but I think in our region it's quite a challenge. Would you agree, Professor Irani?
Yeah, I think everywhere in the world, when you go to conferences, compliance is an issue, but education is the key. So
absolutely. Yeah. I think we'll stop here, and I just wanted to remind our participants of 2 things. One is, just hang on a second. I hope to want to remind you and to invite you to our conference in which is going to be in early February. So please join us there. I hope you can see it there. It's very, very important conference in the region. Professor Irani is going to be one of the eminent speakers there, and there'll be experts from different parts of the world representing different societies, including Apache and ESID and Galen. So please come and join us. It's in Abu Dhabi between February 8th and 9th. So I hope to see you there. And also I'd like to thank our speakers, again, eminent speakers, for their excellent talks and for their time that's given us tonight to be with us and share their experience. Also, I'd like to thank our participants who were really enthusiastic, and in Abu Dhabi now it's 10 o'clock, so we have people are still engaged, so that's really a good sign, and it shows how eager people into learning. And finally, I'd like to thank our sponsors, Talagen Greer, who actually really made this happen, and to Peril for their been there for us all the way and supporting our activity, and for their excellent work. So we'll close here, and I hope to see you next month for another module, if you like. Okay. All the best and good night.
Thank you.
Thank you. Bye-bye.
Thank you. Bye.
All the best. Take care.